Okay, so this is a good case. I mean, this is not the best case ever, but this is a case that has been done during this COVID pandemic, and it is a little. I think everyone is feeling it that when a patient comes in through the emergency from a containment zone with acute chest pain, then one feels bound by duty to operate. But at the same time, there are a lot of anxieties about, is this patient positive? What will happen to the staff? Where will I put the patient? So we have developed a strategy where we can screen these patients. Unfortunately, we do not have rapid diagnostic tests here which can screen for COVID. So we have to wait for 24 hours before we get a report. But at the same time, we have to do something. So what we do is when someone comes in with very severe chest pain and we feel bound to intervene, we take the patient to the cath lab anyway, and we put on our protective gear, and all cath lab staff and the operators. We do the operation, and then we take the patient for an HRCT. And if the HRCT is absolutely clear, we put it in our CCU. If it is not, then we put it in the COVID isolation CCU and we wait for the RT-PCR report. And this strategy has served us well over the past 2 months. We have had some misses where we thought it was not positive. It has come back as positive. And it can happen because it misses the first 3 days of the illness, the HRCT. So here is a similar case. So this is a 58-year-old male patient who has been diabetic, and who is a type 1 diabetic. And he was normotensive, and he presented to ER with chest pain that had been ongoing for 3 days. The first TROP-T done outside by his general practitioner was negative. There were some ECG changes, but not too much. And then the following day, he had more severe chest pain, and he referred the patient to the emergency. And he was coming from a red zone where there were lots of COVID cases. When I saw him, he did not have too many symptoms suggestive of influenza-like illness. All he had was chest pain, severe chest pain. And this time, the TROP-T was positive. And we saw that there was ST depression in V3 to V6. And the echo revealed hypokinetic inferior wall with an ejection fraction of 50%. And when we did the angiogram, this is what it showed. So this is the angiogram, and you can see that the circumflex is nothing to write home about, but the LAD, there is a osteoproximal LAD stenosis, which is about 50 to 60% at the least. But I thought that this cannot be responsible for his symptoms. So what I thought was it was the RCA that was causing his trouble, and sure enough, this was the RCA. And you can see that there are 3 stenosis there, one at the distal RCA, one in the PLB, and one in the PDA. And the PDA actually looks quite a smallish vessel. So we had to quickly think what to do about this. Just wait for the video to run again. Okay, so what we did was there was a very tight stenosis in the distal part of the RCA. Then there was a long tubular stenosis in the PDA, and then there was a discrete segment of stenosis in the PLB. And while we had passed the wire, the patient started developing ST elevation now with severe chest pain. So what we found was that the RCA was an extremely tortuous vessel, and we had to straighten out the bends because we could end up doing a bifurcation stenting, and if it would be very difficult to deliver the stents. So I chose a AL2 guide catheter, and this is a Whisper extra support wire, which I have lodged into the PLB. And I did a quick dilatation of the first lesion, and then I went into the PLB and I dilated the PLB. And you can see that the PDA looks like a very small, miserable vessel. But I always believe that the PDA grows. So what we found after this was we did some further dilatations. And now you can see the PDA growing a little bit, and the PLV angioplasty result is a reasonable result. Now I had to enter into the PLV, into the PDA. Now entering the PDA here is a challenge because you can see the number of bends that are still there even after passing the whisper extra support wire. And every time you pass a wire, it coils around in that two hairpin bends that are there in the RCA. Now, after the flow improves, after you do the initial pre-dilatation of the PDA, it becomes easier to enter. It becomes easier to enter the more difficult vessel because there is now flow, and you can take help of the flow to enter the vessel. And it was not easy at all. We tried, so we had this whisper extra support wire here, and we tried to put an SI Sion blue in the PDA, and it just wouldn't go in. So in the end, I was a little frustrated. So I took the SI Sion blue into the PLB. Sorry about this. Sorry, it is just playing the same over and over again. I'm just stuck. Just hold on a minute. I'll try to sort this out.
Dr. Dev, what guiding catheter was this?
This is a AL2.
L2. Okay.
Yeah, this is an AL2. I can't advance the. Just a moment. Just let me try to fix it. I think the computer is playing up. Okay, it's a little frustrating. So I'll tell you what I did. I put the whisper extra support into the PDA, and then I dilated the PDA. After I dilated the PDA, I looked at this vessel again, and what I thought was I would stent from the RCA into the PDA, and I would not. I would leave the PLB alone. So that is what I did. I put a 2.5 by 18 into the PDA, and then I put a 3.5 by 18 into the actual RCA. And the final result was quite satisfactory. It's very frustrating that I can't show you the final films. And I left the PLB alone. So I ended up by stenting the distal RCA. Okay, let me try this. So this has come out. Okay. Can you see this screen now?
Yeah.
Okay, so it is still, so you can see that the one wire is in the PLB, and now I have managed to enter the PDA, and you can see that the PDA is also very tortuous. And then I have dilated the ostium of the PDA with a with a 2.5 balloon. And after that, I have implanted the stent in the PDA, implanted it, and then implanted a stent in the distal RCA.
So sorry to intervene. You can click on this image and play this in this view also.
Yeah, I'm trying to do that.
Can you go on a slideshow? If you go on a slideshow, maybe it starts playing.
Yeah, I'll try that.
Yeah, and now click it.
Yeah. So now you can see I have stented the PDA, the PDA, and this is the distal RCA. It is my computer. I'm very sorry about this. It is my computer. So after I have done this, I hope I will get the next one. All right. So you can see that there is a little waste there. We did some high pressure dilatation during the stent deployment. And then we did some post dilatation here. And after the post dilatation, this is how it looked. Let me displays. Yeah. Okay. So this is the result. As you can see, the PLB looks quite okay. We have stented the PDA and we have stented this, and you can see this appearance here, which I think is a concertina effect due to this wire. It's not a dissection, so I withdrew the wire there and took another picture, and you can see it is not a dissection there. So I decided that the case should end here, and the only thing that was left was to take the catheter out safely. And what we do is we put the balloon back over the wire, and we take the catheter out with the balloon and the wire in the artery, so that the catheter doesn't dive in as we withdraw the balloon and the wire. So that is the last step of this procedure, where the ostium of the RCA could be dissected by a diving AL tube. And that was the final result. So that was the case. We did an HRCT on this patient. There were features of pulmonary congestion. So we had a little doubt. We put the patient in isolation. We did the COVID test. The COVID test came back as negative. So the patient is now back in our usual CCU. Hopefully the patient will go home tomorrow. We will probably do the LAD at a later date. We don't want to do it right now.
Yeah, morning. Am I audible?
Yes.
Am I
yes.
audible?
Yeah.
Yeah,
Sure.
good morning. Thank you, Dr. P.C. Rath. And because we are running short of time, actually, because I thank Dr. P.C. Rath, Dr. Anand Rao, and Dr. Ajit, and all other speakers for contributing so much academic program. And we will move on to the next session. Thank you, everyone, for the participation.
Thank you.
Special thanks to Dr. Sai Satish, who showed a beautiful cases of TAVIs.
Yeah,
Nice
nice case.
And Dougal's case was very good. Calcified
Very complex.
CTO case, and Anand Rao, beautiful case he showed. And Menon also, two bifurcation. And the end, Dave showed us the case, difficult case with in the COVID era. Thank you all. It was very good session, and hope we'll continue to see some other sessions will be continuing.
Thank you. Thank you very much.
Thank you, sir.
Next session is on COVID and cardiology.